Hi, everyone, and welcome back to the Hopelessly Gifted podcast. I'm your host, Mark Talaga, and today we're going to take a dive off into the deep end a little bit about what happens if your gifted child, complex kid needs a lot more care than the normative services that exist, as is. Maybe therapy isn't totally doing the trick. Maybe symptoms are getting really severe, and we have to look for more support and unique support and support that's still tailored to their complex profile, but has a lot more firepower behind it, we'll say. And I'm lucky enough today to have two women with me that are experts in this area around what it means to go to an elevated level of care, whether that's in a partial hospitalization program, intensive outpatient, residential, what have you. And if all those words make no sense to you, I'm sure they will help explain it in greater detail to see if it could be a fit for you or somebody you know. So I want to introduce Caroline Gulick. She's the Regional Director of Clinical Partnerships, where she supports client care navigation, provides education on appropriate levels of care, and serves as a resource for individuals and professionals navigating the mental health landscape. With an undergraduate degree in recreational therapy and a master's degree in applied behavioral analysis, her background spans autism, physical and developmental disabilities, and mental health across long-term care, hospice, inpatient, PHP, and IOP, and residential treatment settings. She brings a systems-level perspective to care coordination informed by both hands-on clinical experience and international academic work, including presenting research to Serbian politicians and faculty at the University of Belgrade. She is deeply passionate about helping individuals across the most appropriate level of care and programs that thoughtfully address their full range of needs. And alongside her, we have Julie Kastelan. She has a clinical background as a board-certified music therapist and has worked in primary mental health settings for the majority of her career. Julie got her Bachelor of Arts in Music Therapy degree from Eastern Michigan University and completed her internship at MusicWorks in Resounding Joy, Inc., a community-based nonprofit organization based in San Diego, California. She was the first MTBC at Havenwick Hospital, where she helped implement music therapy programming throughout the facility. Then Julie worked for the state of Michigan at the Center for Forensic Psychiatry. Julie is deeply committed to staying connected with her community, actively engaging with individuals and organizations to understand their needs and concerns. She's a strong advocate for accessible mental health care, working to break down barriers that prevent people from getting the support they need. Whether through outreach, education, or collaboration with local services, Julie strives to collaborate and promote mental health resources that are inclusive and available to everyone. Welcome, Caroline and Julie.
Thank you so much for having us today.
Yeah, thank you.
Oh, absolutely. It's a joy to have you. So let's go to just a foundational look as to what kind of supports do you provide for people out there that need it?
Yeah, I think one of the biggest things that, Julie and I, we both work at the same company, and our main goal to help get clients into care is to fit the unique needs of that person. So, we're really big advocates on one size does not fit all.
Mhm.
So we really like to take the time to communicate with that individual and also their environment. Who are their support systems around them? Is it mom, dad, spouse, siblings? Any collateral information that we can get to best support those folks is what we're really in the business for.
And tell me a little bit about these needs. What are the needs that you're addressing? Because I think that's key.
Yeah, absolutely. So some of the needs that we typically really help navigate are mental health concerns that are starting to affect their everyday lives. So ADLs being impacted. Brushing your teeth is a battle as opposed to just something that you do mindlessly. And when I say mindlessly, just like second nature. Different thoughts of, suicidal ideation, things with a plan, intent, and depending on which level, sometimes even utilizing substances as a coping mechanism. We focus on the coping mechanisms that can be implemented into your everyday life to strive for that more functionality.
Right. And so, I want to get into a little bit about how you got into this work, but I want to dive a little deeper into what separates the level of need you deal with in more of a high level right now, that separates the need you deal with versus, hey, I'm just going to take them to a therapist I found on Psychology Today.
Yeah. So kind of what our roles are. So I work on a residential side of the program or the organization that I work with. Wait, can we pause? Because that
Yeah,
didn't sound right.
that's okay.
Let's redo that.
That was
Better.
perfect, by the way. You taking
Thank
that
you.
pause? Well done. And
Thank
then
you.
go ahead whenever
Do you
you're
want to
ready.
ask the question again and then I'll go into it?
Sure.
Okay.
Let me make sure I got the question in my head. I got it. So what separates the needs that you guys address from a parent saying, well, I'll just go find a therapist or I'll look on Psychology Today to address these concerns? When is it like, we probably need to look to somewhere like your program?
Yeah. I think something that's important is to be able to talk about what the continuum of care looks like with primary mental health. So, when we think about the most acute or highest level of resource for treatment, that would be an inpatient level. Then, when you think about the lowest or baseline type of treatment, that would be when you're going to see your outpatient provider, whether that be a therapist, a medication management provider, or any supplementary resource you might see, like a yoga therapist, music therapist, the list goes on. Everything in between is the topic that Julie and I love to talk about the most. So the program that we work with, I work on the residential side of programming. So when we think about that most acute, that's that inpatient level of care. I am right here with that residential level.
So you're right one step below it.
Correct. Yep. We are one step below an inpatient level of care. So, especially in Michigan, residential treatment for mental health is something that wasn't previously utilized really up until about 2 years ago. So, there are a few other residential programs here in Michigan, but they're typically more niche programs for adolescents or primary substance use. There isn't much resource for that primary mental health piece for adults. So a lot of the folks that we help support are people who are stepping down from an acute care setting, whether this be a med-surg hospital or an inpatient level of care. The thing that makes residential a little bit different is that our infrastructure is able to help folks that maybe aren't neurotypical. So maybe their communication styles are a bit different. Maybe they, get, overwhelmed with their sensory needs and they need people around them to have more of that supportive environment, more one-to-one resources, people who really understand where they're coming from, because maybe it's hard for them to just communicate their needs right up front and be vulnerable.
Right.
And we'll kind of get into more of what that means, but I'd love for Julie to share a little bit about her role.
Yeah, so I work primarily for the partial hospitalization program and intensive outpatient. So that is the level below residential and above outpatient.
Right.
It's kind of one way that I like to compare it to is like school for your mental health. You go to the partial program for sometimes 6 hours. That's how long the one I work for is. I've seen 8, but normally it's 6 hours. You do group therapy. There's some individual therapy. The program I work for has medication management. And then you go home at the end of the day and try to practice those skills and really implement them into your everyday life. Something that I kind of like to compare it to is like the dentist, for example. For pure outpatient, seeing your therapist once a week, that's like those cleanings that you got to get every 6 months. For PHP IOP level, that's like, okay, we're seeing a cavity. We should get that filled before that starts becoming worse and impacting. Residential is like, oh, that pain, really, really bad. I really got to go see somebody to get a root canal or something. The pain is impacting everyday life.
Right.
And then crisis is like, we got to get some surgery done or something.
Okay. So it's a matter of severity, a matter of how much impact is happening. And,
Yes.
I'll continue down the line as an outpatient provider. This is when I start to think of how do I maybe raise the level, right? Typically when I'm evaluating if a client needs more support, it means that there is some level of rigidity that is so severe, or the family system is so locked up where we can't make an impact almost anywhere, where nobody's willing to allow us in. And yes, the kid is not getting better, right? They're stalling out, or it's just getting worse. And we can't seem to engage them in the process in a way where we're seeing some level of improvement. That is the time for me when I'm looking to, you guys, right? Of, okay, we need something that's a lot more structured, a lot more getting them out of their current environment, which I think is a big deal, and getting them into a place that is built to have a level of structure and support and resources, from medication management to group therapy to individual, like you're talking about. and having that just be a little more daily, mandatory, a lot more frequent. Is that where you feel like you see people from outpatient referring to you? Is it that point?
Yes, typically I really love to prompt to other providers like, hey, if your client is walking out of your session and you're still thinking about your client at the end of the day, if you're worried about their well-being or they're starting to exhibit signs of decompensating symptoms, meaning same thing about those ADLs, difficult, maybe some suicidal ideation conversation is creeping in
Real
there.
quick before I'm going to interrupt you, define ADL for people.
Oh, my apologies. ADL is activities of daily living.
There you go.
So kind of like I mentioned earlier, brushing your teeth, brushing your
Yep.
hair, taking a shower. It's a battle as opposed to something part of your routine.
Right.
Routines start to fall apart a little bit.
Mm-hmm.
And will you repeat your question for me one more time just to make sure I am answering it?
No, you're answering it great. And the idea is, when you're framing to outpatient providers, when should you start thinking outside of maybe this is out of your scope? You're talking
Gotcha.
about it's staying with you all day long. I can't get them out of my mind. I have to, I don't seem to be able to make any headway with them. And the ADLs, the everyday life activities are impacted. Okay, I gotcha. Yeah. Very cool.
And sometimes I've had clients or providers reach out to me saying that their clients are requesting to see them multiple times a week. If they feel like they need to see their provider twice a week, 3 times a week, that's also a really good indicator that they might need a higher level of care and a bit more structured wraparound care for their mental health.
Oh, I really like that. That's actually a pretty key point because a lot of therapists out there maybe have a tendency to unconsciously create a level of codependency with their client, right? I'm this person's person and they should see me as many times as they feel necessary. And I always help them feel good, but nothing's shifting. And so as a really good clinician, you got to say, are things shifting or are you serving as this person's security blanket? And maybe that frequency is a really good, maybe we'll say yellow flag that you should be thinking outside for better services or different services rather.
Yeah. And if the client is contacting you after work hours, more often than is what is comfortable for that clinician or what they feel like is healthy for that clinician, that is also a really good indicator to kind of look inward and say, am I what this person needs right now, or are they needing something a little bit higher for levels of care?
Now, what gets you guys into this level of work? Because you're talking about, moderate to severe, difficulties with people. What do you feel like makes you guys, connected with that work?
Yeah. Do you want to go first?
Yeah. I think something that really made me want to be in this role to help navigate the conversation.
Here, I'm going to stop you real quick because your microphone was getting real wonky on me.
Sorry.
Yeah, that's okay. I don't know if it was the direction, but we'll take it again and just talking about your connection with the work.
Okay, perfect. Do you want me to just start speaking?
Yeah, go ahead.
Okay. I think something that got me into my line of work is, I really started to see when I worked on the clinical side at an inpatient hospital, I would see the same folks come right back into an inpatient level of care. I remember there was one day where I started my 8-hour shift. And there was an individual who discharged from our program, our inpatient hospitalization, and she came right back right before I had left for my 8-hour shift that day. And it made me think there has to be something else. There has to be something that we can do to provide that continuum of support so that people are learning more tools in their tool belt. And that's really what residential is. It's an extended length of stay, typically 30 to 45 days, where not only are you stabilizing, you're also learning skills. And then you're learning how to facilitate those skills and use them in your life. I think a lot of people, when you go inpatient or even at the outpatient level, you hear these words like dialectical behavior therapy and acceptance and commitment therapy, cognitive behavioral therapy, all of these really fun and great modalities. However, I think people don't learn how to put them into work. And so that's really what made me want to get on the residential side to help navigate the conversation, because it can be really overwhelming for people.
Yeah. And for me, I, with my clinical background, both being starting a program at a psych inpatient and then working at the forensic center, At the psych inpatient, I would also see the PHP IOP. So I've seen the entire spectrum of mental health from PHP IOP outpatient all the way to forensics. And one thing I would find myself wondering is like, what if some of these people got into the right level of care that they needed when they needed it? Maybe some of the guys at the forensic center wouldn't have committed their offense, and then they wouldn't have to be at this level and point. It's just something that is a difficult thing to navigate, especially within the nuances. Like, there's a reason why there is a job like this that exists.
Oh, yeah.
The nuances within mental health and the medical world in general can be incredibly difficult to navigate. And you have to know all this jargon, you got to know what to look for. And then half the time, there are so many people I've heard tell me they went to find an outpatient provider, whether it was PHP or pure outpatient, and they were really disappointed with the treatment that they got. So
Right.
we love to develop relationships with providers such as yourself and be able to send people in our care to people that we trust. So that way we know that we're kind of stopping that revolving door, so they don't have to continue coming back.
I love it because you're taught, it's kind of like the buck stops here. We want to really make sure we're assessing correctly so that this isn't something that just keeps happening over and over as a pattern, right? What are the systems involved? What's the level of care needed? We might be missing something, which is great. That's great clinical work. So, but there's something that you brought up that I thought was interesting. The idea of, a parent or a family or an individual going to try to find care and then ultimately feeling disappointed. And on one level, yes, we could look at, the care wasn't correct or what they needed. That could be. But on another level, it's managing the expectations of parents and families and individuals about what it means for this kind of work to work, right? So how do you go into a place where, you have a parent that's asking something along the lines of, is your IOP, is your partial hospitalization program going to work for my kid? And, obviously underneath that, they have their own level of expectations around what working means. How do you guys handle that in your process of managing those expectations?
Yeah, especially on the PHP IOP level, I definitely resonate. Parents really care about the treatment that their kids are getting, and I love that. And one thing that I always try to do is communicate very clearly, like, whether or not you choose to go forward with our treatment, if you do, these are the things that we do, and these are the diagnoses that we treat. This is how things usually go in our program, and this is how well people usually do in our program based on their presenting symptoms. So kind of like how Caroline mentioned earlier, it's not like a one size fits all type of thing. It's a very autonomous program, and we try to work with them as opposed to telling them like, hey, this is the program and it is what it is. Granted, we have structure within our groups, but at the end of the day, we're willing to work with that client and the client's family and communicate with them as much as possible about the expectations. One of the expectations being you go to group and, take part in the group and go through the program. One of the expectations we are willing to be flexible on is like things like discharge date. Just because somebody comes into our program and they are given an estimated discharge date, if we feel like they need more time, we'll have that conversation with them. If we feel like they're doing really well and they might even be able to step down back to pure outpatient early, we'll have that conversation with them. But ultimately, at the end of the day, they're driving the car. We are telling them like, hey, you should turn right here. If they don't turn right, we'll be like, okay, let's make 3 lefts to get us back on track. So you just try to be as communicative and educating as possible and collaborative.
I think something else too is when we have these conversations with family, we always like to look at what the underlying question or what they're looking for. When I get asked, is this program going to work for my loved one, my daughter, my son, whoever it might be, the first thing that I like to ask is, well, tell me about your experience in other programs, because that tells to me the things that's important to them. Is communication really important to them? If they are signed off on a release of information, do they want regular updates about their loved one? Do they want to be brought in for family therapy? Is it about, the recidivism rate,
Right.
for their individual? What are the things that really matter to them? And what do they define as, is this program going to work for my loved one?
Right. Exactly. So good. I like that. So here's what I'm going to do. I'm going to do a little something goofy. I'm going to role play. I'm going to be a parent And here's what I'm going to say. And then I want to see how you guys would react to that parent. Okay. So, all right, my kid's going in here. It's costing me a fortune. It's not really, but and all I want is for them to be able to brush their teeth every day. I just want them to brush their teeth and do their homework. And when they come out of this program, I want them to be able to do that.
Yeah. And something that I would probably say is I completely hear that need because being able to participate in your activities of daily living is the structure of your life. You know, brushing your teeth, brushing your hair, showering, all of these things are important for us to then live a successful well-being life. So something that we do at our residential facility is we make sure to have time for life skills. So we get to teach our clients the importance of these things. Oftentimes it's not just, oh, I don't want to do it. I'm not motivated. There's a stimuli or there's a barrier there that we just need to figure out what is blocking the ability to take care of, our ADLs. So something that we're going to do is we're going to sit down with your loved one and we're going to walk through an average morning, talk about routine, talk about the things that they typically do. And then for us as professionals, we get to figure out how we can best intervene so that it works for you. Something that I also love to do is kind of talk about the importance of we know that this loved one that's coming to us, they've lived 100% of their days in their life.
Mm-hmm.
Nobody knows themselves better than themselves.
Mm-hmm.
And so they are the expert in them. However, there might be things that they are not having awareness of. So having that communicative relationship where we're collaborating one-to-one and being able to really sit down and have the time to break through whatever barrier is there, that's what's going to allow us to figure out how to best help that person.
Now, here's what I got to react to. And then I see you ready to speak, Julie, but I'm going to hold you for a second. The idea of what you're really meta communicating on such a wonderful level is we are here to create awareness about how deep this goes. Yes. This issue does not happen in a vacuum. It is not a failing of this kid. There is a lot that does not get dealt with, touched on, talked about, and this kid has a limited view of understanding of why it is the way it is. And so with a structure like that, with a program like that, when you're creating the awareness where that, individual now has to expand their understanding of why brushing my teeth is as difficult it is, not I just hate it, I don't like the feel, there's more, and you're walking them through that in a very concrete way. That changes things for sure.
Yeah, it definitely does. And, I think a lot of times when we observe a physical behavior, whether that be, let's say, a flat affect, we might assume they're not motivated. Well, maybe that has nothing to do with motivation, or they're depressed. Maybe it's not about depression, let's be curious and let's prompt and let's ask more questions. What were you going to say?
And I just kind of adding on to that, that's where that collaborative piece comes in and communication. It's like, okay, I hear that you're concerned about this for your child, and this is an important aspect of for your child. Can you please tell me more about why this behavior is really concerning you, how long this behavior has been going on, and what made you feel like you really wanted to bring it up today in regards to getting started with this treatment. So just trying to understand, and like Caroline said, be curious where they're coming from with this, and oftentimes how we can fit in there and educate a little bit more, like Caroline mentioned, understanding where this behavior is coming from. Right. There are times where we often assume things based on our own personal experiences. But until we ask and try to learn more and understand, it's difficult to say whether or not you want them to do something.
There you go. And again, you're also communicating to parents, hey, if this problem were easy, you'd figure it out. But the reality is it's complicated and there's a lot more depth to this. And so I do really appreciate that systemic approach to looking at all sides, all things, and not just jumping to whatever your bias might be based on a person's, initial meeting of them. I think that's really cool. So, the idea of, maybe finding a program, I kind of understand why I might need something like this, or my therapist has said, this is getting outside of the scope. And so this is the next step. And let's say they get them there and they're there for however many weeks. What is the step down process? How do you prepare parents and the individual to transition out and back into whatever they're heading into?
Yeah. So for the levels that I work with, which is partial hospitalization, intensive outpatient, we also offer a family therapy session. Sometimes it's more than one, and it's usually set up towards the end, towards as we're getting close to their discharge date. And what that does is we're able to bring the family in and give them more information about what their loved one has been working on, how they best can be supported as we navigate really stepping back into everyday life and functionality, and what kind of things they can do to help on both sides. It's
Right.
got to be a collaborative approach from both sides, the client and the parent. We have to figure out how to communicate that. If the client is struggling, the loved one, how do we let our support system know? And if we let the support system know, how does the support system then say, okay, this is what we talked about. We talked about these supports. Let's go in and support like that. So that it's a communication and conversation.
Yeah, I think continuity of care is our number one goal. You know, I like to kind of think about it is, let's say you slip and you break your leg. Well, you've got a cast on your leg and you get the cast off. Often you're not just going to start trying to walk independently without guidance from a physical therapist. Well, the levels of care we kind of bridge, as we said, inpatient, then residential, PHP, IOP, and outpatient. At the residential level, our goal is to be basically that physical therapist, but for your brain, for your mental health. So being in an environment where you have room to explore who you are, you have a room to explore these traumas and these, you know, barriers that maybe made you feel dysregulated in the first place. And part of Julie and I's role is to connect with the community so that we know what resources are out there. I always like to say I have the best job because I get to be in the know of some of the most skilled providers in the state of Michigan, which not many people get to say that, but Julie and I do get to say that.
Yeah,
So
you
for
have
us,
to. I love it.
yeah, we take the overwhelming feeling off of these families because typically when somebody starts off at our residential facility, then they go down to the PHP level, so the partial hospitalization program, and then they go to the intensive outpatient program, and then they go see their provider in the community. Well, if this person does not have a provider in the community, that's where Julie and I step in and we say, we actually know some really great people that meet all of your specific need criteria. Let us get you connected with them.
Gotcha. So yeah, you're talking about how at the end of the day, you're getting into this person's life, getting to know them, getting to know their family, getting to know where their supports are and are not, and then creating something where you basically giving them a built-in support network of here's how you're going to utilize this, rely on this, maybe what to look for, how you need to, communicate with one another, and how you handle things as they might come up again. Because the reality is it does, right? You're going back. Yeah, go ahead.
I was just going to say life happens and mental health doesn't stop for anyone. Like our goal is that we are able, like I almost think of it as a parent. A parent needs to trust that they taught their child, right from wrong, values, morals, all of these things. We want to trust that we're teaching these individuals skills so that when they do discharge from our program at no matter what level it is, if they start to feel dysregulated, they start to feel heightened, they get to go into their tool belt and say, oh, there's a nail on the wall, I've got to grab a hammer right now, instead of grabbing a screw for a screwdriver. So really being able to know what you need in that moment, what skill to pull from, so that you don't come right back into a higher level of care. And if you need to, that's also okay. We're here for you. But our goal, like you said, the bus stops here.
Right. It's funny. It reminds me of I think they did like a retrospective. You remember the show, The Biggest Loser, that weight loss show or whatever? Right. Yeah. So, people would be on that show. They'd lose, they'd basically transform their whole lives and body and everything. And they were able to do it when these people said, I've never been able to do it before. And then they did a retrospective to check on where they were like 6 months or years later or whatever. And it was out of the past 13 winners, only one person kept the weight off in a way that they sustained it. And again, it wasn't a moral failure on anybody else's part, but it was the reality of returning into a system that is going to bring back all the things that kind of try to get your brain to go backwards and rewiring it to how things used to be. And what you're talking about is, no, we need to find new ways of being, really change the way you address and handle things outside of these walls where you're doing a lot better, you're feeling better. and helping parents and families understand that you're going to have to create changes. Otherwise, things tend to regress back to the mean of what it was.
Yeah.
Right. And nobody's perfect, right? Especially people going through mental health challenges and things like that. It is very difficult when you've done something the same way your entire life to then suddenly change it up completely. So we're not saying like after you leave our program, you're never going to come back, but we're saying like it might take a couple of times, it might not, but we're still enhancing and working on these skills and reinforcing these skills to
Right.
kind of try to rewire our brain, even though our brains, we don't like change. We like to stay the same. We like to do things the same way. So it's not an easy feat at all. But we're willing to work with you and continue working with you. Ultimately, the goal is not to be a revolving door every time our mental health really decompensates.
Yeah. And the only maybe sin that they commit, so to speak, is maybe underestimating the complexity of how hard it is. And and to come back to something where you're like, oh, I thought I did this already. I'm not making any progress. Not at all. The reality is this is as hard as it is to make change that you're looking to make, and coming back to something that you found functional and then trying to explore it a little further and deeper and get clarity. Guess what? That's the growth. That's process. Yeah.
And research shows when we're uncomfortable, that's when we grow the most. And two, I think it's important. So at the residential facility I work at, something that we do that's really neat is we actually have the social integration model. So what we do is once we stabilize folks, we take them out into the community at, maybe a local grocery store, a coffee shop, Target, things like that. And we get to test that the treatment we're providing is working because it's almost like a safety net. Our professionals are there to be with them if they feel like they're dysregulated or heightened or they're feeling triggered by something, so that we can help them in real time say, hey, let's go to the tip scale, let's go pull something from dialectical behavior therapy and let's be able to regulate. And if we go out into the community and we realize they did feel a little bit triggered a little bit easier, that tells us, hey, we have more that we need to work on. Whereas if we take them out into the community and they do a really great job, well, Rockstar, you're probably ready to discharge a lot sooner than we thought that you were. So I think it's important, whether it's the programs that Julie and I work, with, or another program, being able to be in an environment where you're also able to test the theory that the work that you're going through is, it's helping you. I think that's something with, an inpatient level of care. When you get discharged, sometimes it can be difficult to know what's next. Where am I supposed to go? I might not be right for pure outpatient, seeing my therapist once a week or once every other week. That doesn't feel like enough. That's where we step in to help navigate that landscape.
Oh, that's great. I mean, yeah, you're a guide, you're a Sherpa, you're teaching, you're a teacher, you're a coach, you're a therapist. I mean, you're all of it. I mean, again, that's the necessity of what it takes. And I love the idea of real world practice, because again, that is how our brains create, neural connections and myelinate and get stronger, is through the actual behavior and doing it in a safe way and helping kind of, field test some of the skills that they're learning in maybe more of a theoretical, emotional way out into a practical way. That's a huge help for a lot of people. Where do you feel like parents are maybe afraid to call or reach out? Where do you feel like the fear comes from for them in going to a higher level of care?
Yeah, honestly, something that we've heard from parents, and let me know if I'm speaking for you here,
No, you're good.
It's just like the lack of knowledge, and it's nobody's fault. This system and the continuum of care is kind of a more spoken of concept in Michigan. It was, 5 years ago, I don't think a lot of people were talking about different levels in between psych inpatient and pure outpatient. So oftentimes, especially with partial hospitalization programming, they get scared of the word hospitalization. They're worried that it's psych inpatient, and they're worried about their child being isolated or re-traumatized by something, things of that nature. So for me, at least, it's the lack of awareness of these systems and of the continuum of care. You don't know what you don't know, and oftentimes you don't know until you need it.
Yeah, I think too, like with the lack of awareness is also connotation or stereotypes that are out there.
Right.
Like you said, when people hear partial hospitalization,
Mhm.
I think a lot of people think a cold clinical room, you know, white or gray walls, everything's very sterile. Or even when you hear the word residential, even that word can feel heavy. But when we break down what residential actually means, you know, this isn't a scary old 1950s film. This is a place that's restorative, and, you know, it's a beautiful location. We've got couches and living rooms and blankets, and, you know, we have productive environment is very important. If you don't feel like you're in an environment where you can heal and you can be vulnerable and share what got you to this point in your life, you're not going to do the deep work that residential is made for. You know, I think something else is feeling comfort and being able to almost trust a resource. And sometimes parents, you know, we get calls all the time of whether it's, you know, 9 to 5 or at 2 in the morning, of families who call us and say, you know, my loved one or my daughter, my son, whoever went to X place and X happened. And then for us, we get to educate then on the level of care. I think for a lot of people, when they hear inpatient, they think it's going to be a place where you're learning a bunch of skills, you're getting individual therapy, you're meeting, you know, with your medication management provider for 30 minutes plus, where inpatient is made to keep you alive. You know, you're physically not going to harm yourself. You're physically not going to harm someone else. And so being able to be in a next level of care where now you're stabilized, you're alive, and you're, you know, working through that. Let's actually do the groundwork of what got you there in the first place.
Right.
And if I could add one more thing, I think parents of gifted kids or neurodivergent kids have spent their kids' whole life advocating for them and being there for them and being like that champion for them, because up until honestly, even we're still navigating through a lot of things about equity and things like that for neurodivergent and gifted people. They have spent so many years advocating for them and potentially feeling dejected or rejected, hurt on behalf of their child. So that's another fear that we run into about whether or not we're going to be able to accommodate their needs.
Right.
If they have sensory needs, are they going to be able to use a fidget toy? Are they going to be able to wear what makes them comfortable? And I can confidently say where we are now, we're super like we have comfy chairs, fidget toys spread all around, and whatever the client and the family members need, if the client needs to bring in something to make them more comfortable, totally fine.
Sure.
And I think having that security and that peace of mind is really helpful and reassuring.
Well, sure. And as you guys are talking, because, you know, the idea that, is this place going to be a good fit? Do they understand the unique needs of my child? Can we talk about that? And yes, this, you know, I do feel like there probably should be a rebranding. You have intensive outpatient, you have hospitalization, you have resident, you know, we could call it something else maybe, but the idea is still the same. And then the idea of struggling to face the reality of how bad it is at home. I think a lot of parents may struggle in that place of, well, if we just did this or just did that, or we're in a process and at least things aren't getting worse. And I think it might be difficult for a lot of parents to say, you know, I never imagined my kid or myself would need something like this. I never saw that as an option. And what would you say to parents that are in that place in their heads?
Yeah, something that I like to, you know, I think having like metaphors really helps people understand the importance of different levels of care. And a conversation that I have a lot with families is, if you had cancer, you would want to go drive to or fly to the most specialized place to be able to work through your cancer and get treatment. Why is it any different for your mental health? You know, I think that we let fear creep in a lot as a protective factor. And, you know, we put our walls up because we think of the what ifs. What if this doesn't work? What if this traumatizes my loved one? What if? But what if it works? What if you took this opportunity and you invested your time into, you know, a system and a treatment level that is much different than anything that you have ever tried before? You know, if you've been inpatient or you've continued to do outpatient, pure outpatient, and that hasn't worked, well, bingo, that tells us you're going to fall in the line of a level of care that Julie and I work with. And that's what we're here for. I think another piece too is when we're able to just, you know, sit and talk with families, to say, this is what an average day looks like.
Mhm.
This is how we're able to accommodate the needs of your loved one. You know, we implemented a sensory room at our facility. We're able to lower the lighting. We're able to make sure that noise is not overstimulating. We have the infrastructure and staff to be able to take individuals out of groups and do individual sessions if they feel like they're being heightened or overstimulated. So kind of asking questions and, like we said earlier, being curious about what treatment looks like and what your expectations are so that both parties are meeting each other's expectations.
I like that. And again, and then I want to go maybe on the flip side of it, the idea that somebody calls saying, I need PHP, I need IOP. Do you ever go to a place where you're assessing and actually say, based on what you're saying, maybe not? Does that ever happen?
Yes, that happens quite often,
Okay.
actually. Caroline, and that's why Caroline and I work so closely together, because oftentimes it's just a new idea about this continuum of care. And it's hard to sometimes determine what level of care is right for me if you've never had to think about it before. So sometimes we get people in the PHP IOP level, and maybe in their initial screening, they underreported. And actually, we're a little bit more concerned about their safety risk. We can see a little bit more presenting symptoms than what was reported. So then we reach out to residential. We're like, hey, we might need to send somebody to you. And we'll sit down and have that conversation with them. Like, hey, based on your symptoms, your safety levels, we think residential is the best fit for you. That's where we want to send you. Does that make sense?
It makes absolute sense. So you're always evaluating level of care along the continuum of where does this person fit. And sometimes, yes, they underreport. Oh yeah, they're fine. They're just a little suicidal ideation here and there. And turns out, no, they're actively suicidal. We got to shift things around. We got to move things around. Or the other way around. We need to step you down. You're actually doing far better than you realize. You're actually handling a lot more. It might seem scary to lose the support, but here's how we're going to integrate, how you move towards that next step. So always evaluation. And I would say it's the same on our end too. We're always evaluating for, do we need to go up to a level of care that's more intensive so that this person gets what they need? Or are we saying we're going to say we're having you go try more and push up more and grow those skills that you're learning so well? Well, I think this is very helpful. I know it's very helpful for parents out there who maybe feel like they don't know where to turn or what their resources are. And from what I'm hearing from you today, if you really feel like you're at a place where things are more intense than you may be willing to admit or are ready to admit, you can give somebody like Caroline and Julie a call, and they can help you assess what might need to happen next. So if people needed to reach out to you or even are interested in you as individuals, how could they get in contact with you? How could they find you?
I love LinkedIn. So if you want to look, I'm going to voluntold you. If you want to look us up on LinkedIn, we're always hosting different events in the community too. And genuinely, we just love to advocate for appropriate level of care. So if you look up Caroline Gulick or Julie Kastelan on LinkedIn, go ahead and connect with us and we'll connect right back. And you can send us a message on there if you have any questions, and we can jump on a call, meet in person, jump on a video call, whatever's most conducive for you. We are a free local resource for you to help guide you through any, overwhelming feelings or questions you have.
And even if the particular program that Caroline and I work for is not the right fit for you, we have a list of resources and we have so many great relationships. We will send you away with something, because we find that so many people, if they call and they're looking for help and they don't receive that help on that phone call, the odds of them calling again are very, very slim. We just want to help get people into treatment. We're not trying to sell you a car. Right. We just want to get people help wherever that is for them. Wherever is best.
All right. Well, then we'll put those links in the show notes. So if you're interested in reaching out, you can do so. I want to thank you both so much for being here on the podcast and sharing your expertise. And to all of you out there listening, thank you so much. And we hope to hear from you again. Bye-bye.
Thank you.